Very good afternoon. Namaskar and welcome to a vibrant journey through the heart of Odisha, where tradition meets innovation and every eye tells a story of vision and hope. We extend our warm regards to the esteemed dignitaries of OS President Dr. Srimanta Behera sir, President-elect Dr. Sabyasachi Patnaik sir, and Honorary General Secretary Dr. Samir Kumar Patra. And we also welcome dignitaries of AIOS, APAO, and any other society members, all those who are present. Barua sir, and thank you for joining us today. Over to Anurag to start the session.
Thank you so much, ma'am. Good afternoon, ladies and gentlemen. We offer you greetings and regards from the land of Lord Jagannath. This is going to be a 1 hour, 15-minute session, which we have divided into different segments. The first segment would be on technological frontiers, and there'll be 2 speakers in that, and then we go to then we go to the Make Odisha Proud segment, wherein we discuss a few studies, a few projects that have been ongoing, and we have had some solid results coming out of it. Third is we would honor the great son born on Odisha soil, Dr. T.P. Das, and his initiative to start a project in the state of Odisha for his own people called the Sunetra. So 2 speakers will be expanding on that, and along with that, we also have another speaker who would be speaking on another very interesting ongoing project. And finally, we go to the young brigade of the state, wherein we have 3 people coming in with their 3 thoughts. So without wasting any further time, I think the panelists are all ready. With the permission of the chair, let's get on with the show. The first speaker on the technological frontier would be none other than Dr. Ashok Kumar Nanda. There could be no better person to start the proceedings for the day. And Dr. Ashok Nanda, as is known to all of you, is the director of Carvision Eye Hospital, a very dynamic surgeon, somebody who introduced the concept and popularized the concept of phaco emulsification in Odisha. One out of his many initiations and many popularizations. He has established concepts, he has established technologies that was far beyond anybody's contemplation when he went back to Odisha to start his practice. Right now, he obviously is the director and one of the founder members of a very reputed eye institute in the city of Bhubaneswar, and his ideas would just keep on expanding till it reaches the summit. Are we ready with the slides? His topic is going to be...
Where's my slide? Open this one.
Tips to optimize
Open it.
the outcome of toric IOLs.
Thank you. And at the outset, I thank Anurag and the scientific committee of AIOS and OSOS for giving me this opportunity to speak on optimizing the outcome of toric IOLs. We all know now that cataract, being a refractive surgery, we are aiming to achieve emmetropia, and in that process, right, I press this one to go forward. All right. Okay. So in that process, we need to actually plan our surgery well and execute the surgery in perfect order so that we come out with the best surgical outcome that we desire. We can go wrong at multiple places, starting from biometry to transcription error, planning of astigmatism and marking, and many other steps which each surgeon should look into to achieve the goal. We know that about 70% of our patients undergoing cataract surgery have a pre-existing corneal astigmatism of 0.5 diopter or more, and about 30 to 40% of them have pre-existing K values of difference of 1 diopter. So toric IOL do play a very important role in cataract surgery, and studies have also shown that only 75 to 80% of our patients do achieve emmetropia, that means have a residual refractive error of 0.5 or less, and we have a scope of improvement. So to achieve that, we have to choose the right patient in toric IOLs, and the first thing is to know who are not good candidates. Irregular astigmatism, severe dry eyes, macular diseases, and combined surgeries are to be excluded. Keratometry obviously plays the most important role, and you must use two instruments. Make sure that the results are similar, and do it before you do applanation tonometry, either with opticals or two instruments at least. Biometry does play a very important role. We know if at all we are doing ultrasonic biometry, then immersion is a must. But ideal is of course a optical biometry, because it gives a lot of information whose accuracy is very important to choose and put in the right IOL power calculation formula. I'll just give an example of how IOL power formula does play a role. This is a patient who has a 0.75 diopter of astigmatism, and we choose SRKT formula. The IOL power is 19.5 and the expected residual astigmatism is 0.6. Whereas the same patient, if you do Barrett's calculation for this patient, the same IOL, which is 19.5, the residual astigmatism is 0.92. So that means this patient does require a toric IOL. So choosing the right formula is very important, and you get those with the newer optical biometers. During surgery, all these steps do play a very important role. Good central CCC, intact zonules, choose the right design of IOL so that rotational stability is maximum, put the lens in the bag, place the IOL in the right axis, and each of these steps are to be done carefully. If you are doing a central rhexis, make sure that you are doing the right size by marking it on the cornea with a corneal marker with the Purkinje in the center. Or if you do not have that, you can follow the pupillary margin and make it 5 millimeters, not more than that, so that there is a 360-degree overlap of the rhexis margin on the IOL. If you do not, if you have only a caliper, you can just put 4 caliper marks of 5 millimeter apart. If you have access to a digital marking system, obviously that's the best. You need to do the reference marking properly with a slit lamp. You have to, this is not playing, I think. Yeah. So you have to make a horizontal slit. Right. So you need to make a horizontal slit and let the slit go across the pupil over the Purkinje reflex so that it is central, and you mark both the limbus. And after that, the patient is shifted to the OT, and you have a marker to put the reference marks on the cornea. I'm sorry, the slides are not playing. So we also then have access to a digital marker. In that case, it is much easier. So before you put the lens inside, make sure that the antechamber is thoroughly washed, no viscoelastic left. Allow the haptics to open up, and then put it in the right plane, and then hydrate, not too much, not too less. So follow-up is important. You must make sure that the IOL placement axis is correct at day 1 and day 7, and inflammation control, NSAID are a must. So to summarize, choose the right patient, focus on accurate keratometry and biometry, choose the right IOL calculation formula, good central CCC with 360-degree overlap of the lens, and in the bag placement of IOL, and rechecking your axis alignment on the table 1 day and 1 week after the surgery does give you very good results. Thank you.
Thank you, sir. Just one question is allowed. Please.
So can you say, to have a optimized toric results, do we need advanced technology?
Yeah, that is a good question. See, there is something called perfection. So you can do toric IOLs if you do not have an optical biometer, as I said, with a immersion. Your keratometry has to be good. So you must at least have a manual keratometer or a autoref keratometry, and make sure that the K values are similar with similar axis. Posterior K does play a role in majority cases. It may not, but in some cases the posterior and anterior K derivation with a thin lens optic formula will be probably you can escape, but with a thick lens IOL calculation formula that may actually become wrong. So ideally yes, but still in 75 to 80% of cases, even if you do not have an optical biometer or a digital marker, you can still achieve your target.
Thank you, sir. So, innovation is the heartbeat of progress. Let's begin with pioneers who are boldly pushing the boundaries of ophthalmic care. Our next speaker is Dr. Anurag Mishra.
Thank you, ma'am, and good afternoon, ladies and gentlemen, yet another time. I'll just extend the points that Dr. Nanda has already made. We have different IL calculation formulae available to us in the form of the preloaded things that they have on the biometry. I'll tell you how do I coalesce all of them in my practice to give me the most optimal result that I look for. The first formula obviously is the Barrett's IL calculation formula, and all of us use that. These are the whole gamut of Barrett's formula that are available to us. The last of which has been highlighted. It's called the TAL, or the True Axial Length Formula, which Dr. Barrett has modified. It's based on findings of differential axial lengths or differential thicknesses of the cornea, aqueous, lens, and the vitreous, because each of these tissues have a different refractive index. And when light passes through, there's only one machine which does that. It takes into account the speed of light traveling through these tissues differentially and then stitches them up to give us the total axial length. This is available for use only with the ARGOS at the moment, unfortunately, but I'm sure it will come in other machines as well. Now, since we were discussing about the posterior corneal astigmatism, the Barrett's formula is so robust in its algorithm that some of the biometers do have a tomography and they do measure the posterior cornea. But even if you're not measuring the posterior cornea, the algorithm is so solid that even with a predicted posterior corneal astigmatism, it gives us a fairly good result in most of our cases. However, not everything is perfect in this world, and so is the Barrett's. The fallacy of the Barrett is the Barrett will fail to calculate the IL power. Mark my words, it will fail to calculate the IL power if the lens thickness is below 2 and above 0, which means if you want to exchange an IOL, if you have landed up in a refractive surprise and you want to exchange the IOL, the Barrett's is not going to give you an IL power. Okay, there you have to rely on the age-old Holiday calculator, because that's the next best thing that had happened to us before the Barrett's came in. Apart from the lens exchange and even the piggyback IOLs, where the Holiday is the only formula which will give you an IL power, the other thing the Holiday does is this. This right-hand side of the page is called the Holiday IOL Consultant software, wherein it gives you in that green banner, it gives you the exact expected refractive outcome at the spectacle plane post-IOL implant. So you know what is going to be the refractive correction the patient is going to need in the form of spectacles post-operatively. And you can modify that actually. It gives you, these are the segments which you can modify. For example, the incision size, the placement, flipped toric axis, all that. Takes time to explain all that, but this is what the Holiday has and no other formula has. Sometimes even the Holiday fails, and that's when I resort to the Keynes formula. The Keynes formula is something that interestingly has the K, AXL, ACD, LT, and PACI, and apart from all these, it also takes into account the biological sex of the patient. Keynes formula is a very good formula when it comes to keratoconus. So if you have a cone that is not progressing, that is a stationary cone, and you want to go ahead with the cataract surgery, the Keynes formula is the one that I choose. And the other thing where it comes in very handy is the extremes of axial lengths. In contrast to popular belief, the Hofer Q, which we had relied on for hyperopic eyes in particular, the Hofer Q does not at all perform optimally when it comes to the shorter eyes. The Keynes outshines it in its performance. And lastly, I'll come to something very interesting. This is a ray-traced formula called the Oculix. Now, the Oculix takes into account the pre-operative people. I'll show you something very interesting here. The IOL that has been chosen here is the Alcon. This is an Alcon multi-piece IOL. Okay. Now look at the pupillary sizes. These are the pre-operative pupillary sizes. For a 2 millimeters pupil, the best focus comes at 0.171 millimeters. If the pupil size is 3, it extends to 0.389, and the pupil size is 4, it goes to 0.698. What it means is, if you have a preoperative pupil of 2 millimeters, and you compare that with the it comes in here. If you have a preoperative pupil of 2 millimeters vis-a-vis a pupil size of 5 millimeters, the IOL power that is calculated for these two patients will be different. The best focus will come with a 19.5 with the same IOL if the pupil size is 2, and if the pupil size is 5, it comes to an 18.5. Luckily, majority of our patients have a uniform pupillary diameter, and it doesn't go down to 2, doesn't go up to 5. uniformly. The other thing the oculus gives you is the material of the IOL. Which material of the IOL is best suited for this particular patient, taking into consideration the pupillary size and the higher order aberrations that are there in the cornea. For example, in this particular patient, as you can see, the SN6ATT, which is the axis of IQ, has the best conglomeration of those black spots, vis-a-vis another patient wherein the Clarion outshines it in its performance. Takes a little bit of time to get adjusted to know which material is the best for which patient, but with time your optometrist and you yourself as a consultant get adjusted to it too. So I feel that the ray trace formulae will hold a very, very important place in the future. So this is how my flowchart works. The Barrett's is always the master band of the orchestra. The cane I use for extremes of axial lens. The Holiday consultant software, particularly for planning torics, both in monofocals, trifocals, and EDOFs. And the Oculix, if I find a preoperative pupillary size abnormal and finer adjustment in terms of the material. Thank you so much for your attention.
Thank you, Dr. Anurag. One question, please.
Yeah.
So while the question is being asked, our next session is on Make Odisha Proud. From the roots of our heritage to the heights of global recognition, these stalwarts make Odisha beam with pride. The first speaker is Dr. Sujata Das.
So is Oculix software is available in all the biometers or
No,
in the
no.
Argos or
So
online?
At the moment, it's not available online. It's a licensable formula actually. So obviously it will not be free. At the moment, it's preloaded with the Anterion. But I don't know what the future beholds though, because it's a licensable thing. You have to pay to use it. So whether or not they'll open it to be used with payment or not, it's something we'll have to see. Can you just open the PowerPoint? Olsen is not a ray trace formula, sir. I don't think so. Olsen is, because you have to have an equipment which uses the ray tracing technology to be able to use these softwares, to be able to use this
One more question.
calculation.
Dr. Anurag, in spite of all so many formulae, do you still get refractive surprises, and how do you tackle them? Or rather, how do you prevent them?
If the patient chooses what we choose for the patient, then 99.5% of the time we will not land up in any surprise. Having said that, there are the ELP calculation, however complex it might be, we are trying to decipher it for decades now, but we have not been entirely successful. So to answer your question, if you keep the boundary to be 0.5, I do get surprises, but beyond 0.5, it's very, very rare. Nowadays, it's very, very rare. Over to you, ma'am.
Good afternoon. Thank you OSOS and AIOS for giving the opportunity. I'll be speaking a iBank journey for more than 2 decades now. So we started in 2002, much before LB Prasad Eye Institute. I think we can leave that.
In the meanwhile, our next speaker, Dr. Santosh Mahapatra, can be ready on.
Okay, so we started in 2002 by few people from Bhubaneswar and Cuttack in 2002, and LB Prasad started in 2006. You can see the photograph in 2007. If you can recognize the then Chief Minister of Odisha inaugurated, and this is a synergism between LB Prasad and Drishtidan. And I'm happy that one of the founding member, Professor Padi, is present here. So the journey started in 2002, but the first cornea we retrieved in 2004 September. It took almost more than 2 years to get the first cornea. So you can see 5,000 mark we reached after 2016, and it took 14 years, 2 to 14. And the next 5,000 in 5 years, and another 5,000 in 3 years, and I'm expecting next 5,000 will be in 2 years. So this is now, East Zone is the list in India. In India, we almost collect around 50,000. So Drishtidan Eye Bank contributes to 5% of Indian collection. And last year it was 6th rank, before that it was 8th, and before that it was 10th rank. So every year it is jumping 2 rows. If you see the voluntary and SCRP, again I have divided into 2 decade, and the last one is only 3 years. So the numbers, absolute number, if you see both the hospital corneal retrieval and voluntary is increasing, but the proportion of voluntary is not increasing. The absolute number is increasing. Probably the SCRP numbers are more. However, we need to increase the voluntary also. Same, if you see, it is 15.4x in this 10 years in journey. If you focus this number, the LBP network we used to start with first decade, we used to 70, almost 60, more than 65%. In the second decade, it is reverse. So we have started sending outside LBP also at 64%. If you see the last 3 years, is still increasing. So basically, the utilization is increasing. The utilization is very high compared to other. So it is not only the number of quantity, it is also quality. If you see the lamellar keratoplasty number also increasing. However, in India, I always say that because therapeutic keratoplasty is the majority number, so it will not cross, but lamellar keratoplasty, that means the lamellar surgeons are increasing across India. So again, within Odisha also the number is increasing, the surgeon outside, everything is increasing with the time. But the number outside, it is dramatically increasing because, so where do we get the cornea? To start with, it was only in Bhubaneswar, then we expanded to Cuttack, but now you see the most of the district, it is the corneas are coming and it is like a spoke and hub model. They come to here, then we do the evaluation, again we distribute throughout the country. Last few years, we started adding one more SCRP center every district. Now the focus is on southern Odisha. And getting from the Odisha, we distribute throughout the country by train, flight, everything. And if you see the optical lamellar keratoplasty number is gradually increasing. So not only again the quantity, the quality. You can see Harminder Dua visited us in 2016. We started doing automated keratome, and we are the few eye bank who distribute pre-cut cornea to eye banks. And recently we have started DMAC also. In LBP Hyderabad we started spreading, but in Bhubaneswar also with few months we will start distributing. And what is the impact? So basically the children, you can see that is a sclerocornea after corneal transplant. And people of Odisha do not have to go out for the cornea transplantation. And it is 0 waiting list in Odisha from last few years. Maybe initially 2007-8 we had, but for last 10 years, 15 years it is 0. So this is possible not only for the few people. We started in 2002 and you see this is 2024. When we celebrated our 20 years and 10,000 cornea. So basically teamwork requires commitment, hard work and follow through for this success. Thank you.
Thank you, Dr. Sujata. Any questions?
I invite Tapas to the podium, please, for the next talk.
Hello, ma'am. So, what were your challenges when you started early on this iBank, and how did you overcome these challenges when you faced newly, when it was newly started?
I think it is universally for all eye banks. First is the awareness. So because we saw 2002 March it was started, and 2004 September we got the cornea. Mainly the awareness. Although the number is increasing like anything, still I feel the awareness is not gone to normal. Voluntary proportion is not much. So basically the challenge is awareness.
I think it's awareness of both like whoever the patients are going to donate and their families, and also the hospitals also. Like
yes,
even the hospital also has to be aware that they can do this freely.
Yeah, the hospital side, still the awareness has increased. Much what we started in 20 years back, it has increased. Maybe the voluntary will take still more time to
more
get the cornea.
acceptance is there.
Just want to know one thing. In trade, there is an US company who is selling human preserved corneas, and they are supplying throughout the globe. So how is it possible?
It's a bioengineered cornea. There are a lot of companies
no, human
who are
cornea.
working.
They say it is human cornea, sterile and preserved.
Yeah,
and
okay. Okay, that gamma irradiated, all
And the-
those are mostly.
And the cost is 500 US
Yeah.
dollars.
All those gamma irradiated and cryopreserved, most of them are for lamellar keratoplasty, not for
No,
full
no,
thickness or endothelium.
No, for everything. They have. Just now I talked to them.
Usually
and
tectonic purpose, not for
no,
optical
for all,
purpose.
for optical also they are saying, and the cost is 500 US dollar for each one. Then they are ready to supply to anywhere.
Yeah, but whatever existing, most of the artificial
I
cornea,
was surprised.
bioengineered cornea
I
are
was
for
surprised.
stromal,
That's why I am asking
stromal
you whether.
substitute.
No, whatever it is, it's a breakthrough, ma'am, and I think if it's already available,
Yes,
you
you're
do
on-
have a scope to go and talk to the person concerned, because if it has to be clearly outlined for
Yes,
in the
yes,
coming
yes,
days,
yes.
whether it's possible or not. So you being a pioneer in the same,
Yes,
please find some time to go and talk to the person yourself.
So, very good afternoon. Thanking to the Odisha Ophthalmic Society and All India Ophthalmic Society, I venture to take you to this through this important initiative on real-time ROP telescreening that we adopted to address a huge gap between the ever-rising number of preterm births and ROP-related blindness in India, and so also in Odisha. So these are the different types of ROP, the strategy to address the ROP-related blindness across the world. This includes in-person ROP care at the bedside, where the ophthalmologist or ROP specialist goes to the patient in the neonatal intensive care unit and deliver care. The second is the babies referred to the ophthalmic unit, but this is always not feasible. Many a times babies are sick, and transferring them can be at risk. So to address this gap, the telemedicine have come to our help, where trained photographer go take the images of the babies at the bedside. They capture the images, store and transfer it to a remote ROP specialist, who analyzes it and communicates the result to the patients or to the local paramedics. But the lacunae here is that there is lack of a patient-doctor connectivity. Many times, many thinks that this is just a technician-driven. To address this gap, we developed something called as real-time ROP telescreening, where the monitoring of imaging, analysis, counseling, checkout, everything happens in real time. And this we published in IJO, which has got an award for this year. Now, what is real-time ROP telescreening? The trained paramedics go to the periphery. They take the images of the babies at a remote periphery, and these images are taken in a laptop where the video conferencing software is already installed. So this is being tracked by an ROP specialist sitting at a command center at any distance. Now this finally, when the images are taken, the ophthalmologist and guide can track and guide the photographer to take image any particular area or clarify any doubt. And finally, there happens a face-to-face communication with the patients. They are counseled, and their the baby's disease profile is communicated. Finally, the parents, out of the 50, 60, 100 babies, few of them come to the ophthalmic unit for treatment. What are the advantages? In addition to the advantages of telemedicine, the uniqueness number one is that the re-imaging is feasible in case we want to focus on certain area which is not clear in the picture. The available technology all everywhere misses this, but here we have an opportunity to take again real-time training on a wide scale, like any number of doctors can get logged in and get trained during the face-to-face analysis and discussion with the subject. The group counseling becomes easy. Group counseling where the patient comes over, the RBSK staff comes over, the pediatric support staff comes over, our team who are going to receive the babies also comes over, and at a time everyone talks to face, and things get sorted out, and so that when the baby comes for treatment, everything goes on smoothly and they get treated quickly. So this is just a 1-minute video on our experience over over 1 year. So this got awarded at the Project Management Institute, the project of the award NGO category. So these are the few numbers, over the last 2 years and 9 months, 1062 telescanning sessions, almost 11,407 imaging, and 8,807 preterm baby screened. What is important is 1262 eyes have been treated over 2.5 years, which is a huge number, and this was possible because of the technology. Few examples like this left out baby, unknown baby in the jungle of forest of tribal area in Mayurbhanj got rescued and treated by this technology, and there are many such examples. So to conclude, real-time ROP telescreening has many advantages over existing telescreening model for ROP. The important ones include monitoring and re-imaging in real-time feasible, face-to-face interaction or group counseling has many advantages, excellent scope for training and documentation, but this has resulted in a huge scale of our program in the state, but there is a huge way to go, and I acknowledge the support from all of them shown here. Thank you so much for your kind listening.
Thank you, Dr. Tapas. You want to ask a question?
Sir, how do you see the future for real-time ROP screening in India?
So I got excited when I introduced this. I introduced this during COVID time, but I slowly realized there are two hurdles here. One is the image. The person who is taking imaging has to be very skilled. Number two, you need to have a very good internet connection. If you don't have in the periphery, then sometimes the pictures might not be adequate quality. The third is, if the examining ROP specialist also need to be there in real time, that also takes away some of the time. So what we have modified it, and where a second level photographer who are trained and certified to detect treatment warranting ROP can sit and decide on which are the babies or filter out who require treatment. Those 2 to 3 can be shown to the ROP specialist. So that way, at one command center, you can connect to multiple areas in a day, and we can connect to entire all the districts in the state.
Even AI can also help to screen out the normal babies who are not to be.
Yes. So AI model can very well be incorporated in this. Actually, that will be again another future for this time.
The future is great.
Thank you. Thank you so much.
Thank you. Ma'am. Next speaker.
The next speaker is Dr. Bhagavat Naik.
Yeah, so respected
Over to you, start.
faculty and so thank you OSS and All India Ophthalm Society APO for giving this opportunity. My topic is management outcome of white cataract based on new biomarkers and ultrasonography. So I will quickly go to this just history. As you know, this gentleman, we are celebrating 75 years of first IOL implantation, and our journey went through like this: couching, ICC, ECC, phaco, and flax. But still, in our country or in this part of world, MSC, HMSC white cataract still the show, and presented with phacomorphic glaucoma, phacolytic glaucoma, difficulties in capsulation, phacoemulsification, longer surgery time in terms of CD, more chance of complication in terms of vitreous loss, general dialysis damage, etc. So you can see in this video that what we do is generally we all do in intervention cataract, we aspirate sometimes when the fluid egresses, and after that we can okay. So we want to do a good capsular access. स्पीड नहीं हो रहा है. So and multiple capsule access we have to do because in fear of losing the capsule. So after this then you can do your routine cataract surgery. But sometimes after putting the nick on the anticapsule, when there is a fluid doesn't come, and you may go to periphery, there may be some irregular fluid component in the mid periphery, and it can lead to arginal flux. And then after so many, there are, according to your experience, you will manage this case. So my point is, why we thought for this? You can see the right side. My cursor is not working. The right side, the old photo. That was this photo is of from RP Center in 2008-9 when I was posted in ultrasonography room. I found these things like you can see that there are two signs, two peaks. One corresponding to the PC, that towards vitreous. Another is corresponding to the posterior lens, posterior nucleus. Sorry, posterior part of the lens, that nucleus, and in between that anechoic area is the fluid that means accumulated in the posterior compartment of the lens. So that's why there is a two peak, and here you can see that this is our latest from the AIOS Bhubaneswar. That photo is only there is a cataract. You can see that, but only there is one peak corresponding to the PC. So that I was thinking for this for 10 to 12 years, and then we did some work here. You can see this first video. Here is the intervention cataract. I want to say that in all cataract you will not find. Here you can see that if you see the axial, that means ultrasonography, you can see only one peak is there, corresponding to the PC. Here you can see, here is the intervention cataract, white cataract. You can see there is two peaks corresponding to the PC and posterior part of the nucleus. So finding on this, we did our work to see the double peak sign in pre of ultrasonography and management outcome. And we found 56% from July to December 2023 in a prospective study. And ultrasonography done in all cases, 6% high IOP in range of 30-34 that was managed with mannitol and all the anti-glaucoma drugs. In this flowchart you can see that out of on ultrasonography 24% had double peak sign, 32 had not. So among the 24%, 12% we given mannitol because we wanted to manage what we can do to reduce the posterior thrust, that means vitreous upthrust or posterior interlenticular pressure we had to accommodate, so that when we enter the anterior capsule, that means the lens will not that come forward, so that in that way can we that means reduce the that means complications. So out of this 0 out of 12 no capsule run away, 6 out of 12 without mannitol group, that 50% patient capsule run away, and who had no double peak sign, 2 out of 32, only 6.25% had with capsule run away. That is statistically significant. So you can see this, that means that double peak sign has that run away. And so we did our work further. In young adult case, you can see that there is a clear crystalline lens, anterior, posterior, both the lens capsule are seen, but there is one peak sign in posterior compartment. Here you can see that is the difference is, we measured the difference between the two peaks, that is 1.14 millimeter, here is 0.78 millimeter. Why I am showing this? We did the distance between the two peaks, and here you can see the 1.99 millimeter. And here you can see that there is irregular, that means anterior cortex fluid In between the lower side, there is a only cortical matter is there, and there is a large gap in between the anterior cortex. The difference is 1.42 millimeter in 2 peak sign. So what we found that more than 1.2 millimeter gap in the 2 peak sign, we are having more, that means complication, more chance of capsule run away. So important points, pre-op ultrasonography focusing on PC and counseling. I am saying that on the, that means above, that means for the generalized way, and the rexis forceps, microforceps scissors should be ready and on standby. Pre-op monitor works in reducing the upthrust as in our project. Aspiration of cortical metal by needle cannula or irrigation aspiration. Very small rexis if you are making, after that do IA and you can enlarge the rexis later. Some people do phacoaspiration of central capsule and cortex, and some do also limited anterior parsonal vitretin, but that is a blind procedure, but some it is written in literature. And backup IOL is must, like 3-piece and rigid also. So our work has been, that means we have got that copyright from the intellectual property of India, and we recently published in as a innovation in IGO. So this is our team. So thank you for kind listening.
Thank you, Dr. Bhagwat. Dr. Namrata wants to ask you a question.
Okay. In our institution, some faculty and senior resident already they trained. They are getting the sign, because the while they're doing it is very important. And there's internal validation almost done. For external validity, one institute from the Nepal, they have read the journal. They have called me, that WhatsApp me, and I have sent their video. They are trying to collaborate with the project with us. For the external validity, we are taking that opportunity for the external validity.
Bhagwat, I cannot resist this question. Intermitence is of two types.
Sir.
Anterior intermittent and posterior intermittent.
Yes, sir.
What you're looking at with the ultrasonography here essentially speaks about the posterior intermittent.
Yes, sir.
If the nucleus is very large,
Sir.
they produces an equatorial block,
Yes,
and
sir.
the anterior and the posterior intermittences are not necessarily communicating with one
Not-
another
yes,
if
sir.
there is an equatorial block, which means in the presence of the posterior intermittence,
Sir.
the anterior part may be absolutely fine and you might not have a runaway rexis, and the reverse is even more dangerous. In the absence of this double peak sign, you can never be sure that the rexis will not run away. How have you looked at this? I mean, is it something that you have?
What you are saying that is right. So we have to work on further, because you are saying that if there is no communication, then
I'm saying they're
this
independent
concept-
entities.
Yes, independent entity. But you are saying that part of some of the intuition cataract, no? Yeah.
Of course
yeah,
it is.
Yeah,
Nothing
yeah,
can be
yeah,
applied
yeah,
as a
it can
rule.
be, but we will work on that, because we cannot know, no? We cannot know. So this is one of the method we are trying. But how we can know that whether the lens is so large? Because in that fluid, if you see the anterior fluid pockets, in most of the cases there is a anterior fluid pocket, but that doesn't mean that posterior compartment has that type of fluid.
That's exactly what I'm
yes,
saying.
Yes, I'm saying that. So that's why out of 56%, 32% has no double peak signs, but among that 3% had run away. So I am saying that majority of the cases where we got the double peak sign, there is chance of, and
You
even
should be careful.
again that is the difference between the double peak sign that we are working further. So. Sir, yes, immersion.
B scan.
Yeah, B scan is more, that means with involved with A scan, no? So that is more.
That is what. That's the reason why he is unable to. He's getting the double peak on the posterior part.
That is difficult in B
So
scan.
That is
all
because
said and
some,
done, what
transparent material is there in between those two peaks lines.
Sir?
Some transparent material is there in between. Fluid cortex.
Yeah.
Fluid. Oh, so.
and the upthrust is more if the gap is more. Very rightly pointed out by him. But nothing. End of the day, nothing beats an AIOS2025 to know whether or not the
But sir,
floccular cortex is.
But the AIOS2025, yes, there was an article I have placed on that innovation article also. But AIOS2025 they show na, that fluid pockets are in various fluid pockets. And second thing, AIOS2025 that it is
Cost.
a very
Expensive.
Expensive. It is all for available.
I said nothing beats. I didn't say
Yeah,
cost.
beats no beats. But that double peak sign will not get that accurate. I have. You will go through that article. I have written that also. Yes, sir. Yes, sir. Yes, sir. It is in initial way.
Okay,
Certainly,
thank
it is
you.
a nice observation.
Thank you, Dr. Bhagwat.
It's a nice observation because we are
Thank
seeing
you.
intumescent cataract since long, but we have never thought of doing this and analyzing in this way.
Sir, actually, I tried getting that double peak sign, but could you please elicit like how much
Yeah.
gain settings and
Jaydev SR or SR is here?
as well as the
Yeah,
with
okay.
scan?
Yeah, we can take this
We can
question
let-
later
we
on,
can take
after
it
the
later
section
on.
is over maybe.
Oh, that's why I had made video. I will send to you. And the proper axial scan, once you focus on the PC, no?
Yeah.
Maximum, most of the time, ophthalmologists, they don't go to the ultrasound.
Okay, Dr. Bhagwat, we
Yeah,
can take
later.
it later on.
Later on.
Okay, thank you so much. So in the spirit of Dr. T.P. Das, we now spotlight ongoing projects that reflect Odisha's commitment to impactful eye care further. So over to Dr. Devasmita Majhi for her talk.
Yeah, thank you. So after all those good technical discussion, let's spend some time in the deep forest of Odisha. So I'll take you through the journey of tribal Odisha eye disease study. So the tribal people have also all the rights to get proper coverage under the universal health scheme to the full range of quality of health services without financial hardship. In Odisha, the 9% of the tribal community of India are residing, and there are 4 districts where more than 50% of the population are the tribal community, and there are 13 communities who are particularly vulnerable tribal group. For example, the Dongriya community, they are backward, isolated, they have poor literacy rate, they are small and diminishing populations. So they reside in the Niyamgiri hills of Raigada district, mostly 3 blocks of the Raigada district. So with the support from Ministry of Tribal Affairs and the SCSTRI and OPLIP, LV Prasad Eye Institute in 2021 started this journey of tribal Odisha eye disease study in the Raigada district, where our secondary center is already there. We underwent the door-to-door screening for the Dongriya community, did a few cataract surgeries in the community, provided a pair of glasses to the community. These things were very new and first time for the community, so there are a lot of resistance, lot of barriers. With all those barriers, we are able to at least screen 89% of the target population, and we found there are more than 7% prevalence rate of uncorrected refractive error and senile cataract in the community. Though people were happy with the pair of glasses, and we published it and we submitted the report to the Ministry of Tribal Affairs. But unfortunately, only 40% of the population could avail the services because of the barriers. So again, in 2023, we went to the same community with the support from Ministry of Tribal Affairs to understand what was the impact. So we tried to only touch the population who were screened more than 30 years of age group. And we went through the focused group discussions, tried to examine the left out patients at their doorstep, doing refraction and providing pair of glasses at the doorstep, trying to motivate the left out cataract patients whether they can avail the surgery at our secondary center level. With all the effort, we could only achieve a few more number of cataract surgeries, and we could distribute another 1,000 glasses to the community. And we submitted the report to the Ministry of Tribal Affairs. By that time, the ministry offered another district, that is the Mayurbhanj district of Odisha, with the help of OPLIP, to start the same eye screening services. The Mayurbhanj district is in the northern side of the Odisha, and it was nearer to Baleshwar and Keonjhar district, where LB Prasad has its own secondary centers. And it has a huge load of tribal community, around 56% of the tribal community, the population of Mayurbhanj district. These are the secondary centers of LB Prasad. So with the support from Ministry and OPLIP, we started this journey to reduce the burden of visual impairment and improve the eye health of the PBTGs residing in the Mayurbhanj district. So there are 3 PBTG communities, that is the Lodha community, Hilkhadia community, and the Mankidia community, who are residing in the Mayurbhanj district. I will go through a small video. Dr. Anurag. So after the journey of tribal Odisha disease 1 and 2, This is the community of Lodha community who are residing mainly in the forest. Their livelihood is completely on the forest material and they live in the jungles. And they are highly addicted to alcohol and tobacco since the early childhood. So with the support from the OPLIP team who are residing in the Mayurbhanj area, we started and screened the team works from the tribal community, trained them at our Keunjha Secondary Center. Then we started the journey in the difficult jungles. These populations are residing only in the deep forest, where the vehicles can't go. The team workers, they traveled kilometers with the bags. They communicated with the Anganwadi workers of the PVTG villages. And this time we modified, we took all the handheld equipments as a mobile vision center to the doorstep. Then the door-to-door screening started. So here most of the female pupil, they participated. As you can see, just like a mobile vision center, anterior segment evaluation, posterior segment evaluation, intraocular pressure measurement and glass prescription was done at the doorstep. And with the teleophthalmology, they were connected with the command center. Few children who were in the school, they were screened, and we are happy to find that very less amount of refractive error was found in this population. It was very difficult to convince the Lodha community for cataract surgery. With difficulties, we were able to at least perform around 70 to 80 cataract surgeries till now at our Keunjhar and Baleshwar secondary centers. So those people where we provided the glasses, we are happy that they were able to pursue their occupation further. So this journey is on the process, the project is ongoing. So for the Lodha community, the livelihood is either forest or sewing the leaves. So with the pair of glasses, the females are getting now more motivated to avail the glasses, but they are not motivated to go to the hospital. They are ready to take the glasses if it is provided at the doorstep. For cataract surgery, the most important barrier till date is that there is no felt need. If there is a felt need, they don't know where the service is available, and these families are nuclear families where after marriage the boys and the girls, they leave their parents. So the most of the parents and the females, they are staying alone, and they are not able to take one handful mouth of food also because of the both eyes cataract. But there is nobody to bring them to the hospital. So they are the pictures with the help of this time with teleophthalmology, we are able to take care of the patients. So the few of the families where both husband and wives are motivated both for glasses and cataract surgeries. And we found the load of visual impairment is within 8 to 9% among this community, and advanced age and lack of education was the most important contributing factor till now. Whatever data we have analysis, the refractive error load is quite high. But in Jasipur and Moroda, these are the two blocks where the load is more and there are more rejection in the blocks. When we compared this community with our previous community that is in the Rayagada, we found the load of refractive error is still now comparatively low and the load of cataract is slightly high. So what we learned from all these four communities that with one unique model, we can't work with the particularly vulnerable tribal community. Every time we have to customize our procedure, and if we are finding this kind of blocks where the load is high and rejection is high, it's better to build a vision center, fixed vision center there instead of going every year with the mobile vision center. So we are thankful to our leaders, our supporters who helped us through the journey. The journey is still continuing. Thank you.
Thank you so much. Just one question. If
nice presentation. It was very comprehensive. Just one simple question. In your view, what would be an ideal tribal eye disease study that you would formulate?
So in till now what I have learned with these two districts that an ideal will be always to establish a fixed healthcare service near to the community to recruit the people of their community, train them, then only their health seeking behavior will change within few years. But not with one time of projects, it will never change.
just follow up. How will you collate all this information to have a more comprehensive thing for the state?
For the state, wherever we have 13 PVTGs in 14 districts of Odisha. If we can connect those areas with the nearby healthcare facility, either a secondary center or such kind of good CHC or PHC with the community, so then only we can resolve the problems. But first thing is their population should be recruited and their people should be trained. Then only they can motivate other people. Otherwise, it will never happen. Because this is possible because 2 girls from the Dongria community are working in this team. So they are ready to motivate the other community peoples. Otherwise, this difficult work is not, and all are tribal children, the team who is working. It's not possible with our kind of population. I felt a lot of difficulty whenever I was in the field.
Thank you, Dr. Debasmita.
Thank you.
The next speaker is Dr. Santosh Mahapatra.
Good afternoon. I'd like to thank AIOS and OSS for the opportunity. Here I am here to discuss light at the end of the tunnel. Is it possible? So as you all know, RP is a non-treatable disease for all of us, and it is associated with more than 3,000 mutations, and more than 1.5 million patients are there, but it don't have a specific therapy. So most of the patients, it is so much degenerated that the rods and cones are not there. So we thought of a therapy which can target all the genetic mutations, as well as a patient who is in advanced stage and not having rods and cones. That's why the multi-characteristic opsin, which is a bioengineered ambient light sensitive fusion protein, came to the minds of Nanoscope Therapeutics, who had contacted me 10 years back in 2015, but it was not believable at that time that gene therapy is possible for the RP patients. And that's why I personally wanted to visit US to see if actually they are doing something or not. This is, they said, it simply can be injected intravitreally, and the target cell is bipolar cells. So this is where I was in 2017 to visit their lab and actually see whether it is actually ongoing work or not. And this is the mice model they have shown me, pre-injection and post-injection, where the mice can actually reach the target. And with this, after ethical approval, we started the journey in 2019 with selection of 11 patients who have been injected with multi-characteristic opsin and divided into 3 groups, the low dose group of 3 and higher dose group of 3 plus 5, that is 8 patients. And they are followed till 52 weeks. We injected only those patients who have just light perception or hand movement in the injected eye and not better than counting finger in the fellow eye. And this is the neutralizing antibody test which is showing all the patients. We ensured that no detectable neutralizing antibody is present in the serum of all these patients, because otherwise the injection will be destroyed by the neutralizing antibody. And the safety was the first concern. The MCO was well tolerated with a good safety profile, and there is no detectable retinal toxicity which was shown on multiple serial OCTs. And there was a good improvement in fiber visual acuity, which had more than 30 letters improvement at end of the study, and which is also documentable by fundus autofluorescence showing the M-cherry expression. This is one of the patients who has undergone Y mobility test, and you can see the behavior of the patient pre-injection, where the patient is trying to find the light which is placed at the level of the eye. 2 panels are there, one is lighted and other is dark, and this is following injection at 16 weeks. Patient is directly approaching light following injection and able to locate it. So to summarize, that 52-week study gave us a good safety profile with minimal adverse effects and a very good score in NEI-FBQ score. And with this, they went ahead for a restore study at US at 6 centers, where they have extended study till 72 weeks. At 52 weeks, they had a good response, and that's why they have extended it to 76 weeks, which also showed a good response with a good safety profile. And to the summary of the study, they have told that the over 2 year period, the improved visual acuity was sustainable. But the US FDA needed a long-term follow-up, at least 4 to 5 year follow-up, to prove the safety before recommending the drug for market availability. And with this, we also published the paper in molecular therapy. And we have done the long-term follow-up study in our center, where all the patients who have been injected with MCO were called upon, and all the safety features were re-evaluated at 42 weeks, and we will be completing the study of 60 weeks in next 2 months. So this shows that the improved visual acuity which is achieved following injection is still sustainable without any long-term intraocular inflammation at 4 weeks, and there is a very good safety profile without any retinitis, choroiditis, vasculitis, ischemic neuropathy, hypopyon on the treated objects, and there is no decline in visual acuity due to NCO treatment, in contrast to the natural history of the disease. So to summarize, the results indicates that VMCO is well tolerated with no reported serious adverse effect. There is no anterior chamber cells or vitreous cells or flare, and no subject required medication to treat ocular adverse event at the 4 years. The benefit of the treatment was observed through improvement in pre-treatment baseline quality of life, assessment of activities of daily living using National Eye Institute BFQ25 score. And with this result, they have applied for a drug license in biologic to US FDA in the first quarter of 25, and they're expecting a approval by end of 2025, and the drug may be available in early 2026, where the RP patients may see the light at the end of the tunnel. And this is subject number 003, who was carried by her son to my clinic and is now able to read the room numbers which has pasted in just at the entrance of our clinic. So thank you very much. And
Thank you, Dr. Santosh. One
questions?
Can we give this medicine at the first diagnosis?
Yes, but now we have just included patients who have advanced stage of the disease with just perception of light and hand movement, because we are still assessing the efficacy of the drug as well as long-term safety profile. Once the safety profile and long-term efficacy is established, we can include patients who have better vision, and they can also be taken up for the first instance.
Thank you, Dr. Santosh. Our next speaker is Dr. Ravindra Kumar Chaudhary. He'll speak on Sunetra.
A very good afternoon to all the respected dignitaries present over here. I will be discussing today Sunetra, the first universal eye health program in Odisha. India accounts for 1/8 of the blindness and 1/4 of the visual impairment throughout the world. For prevention of blindness and visual impairments, which are the initiatives that has been taken globally and is at national levels and is at state level, Sunetra, which comes under universal eye health. As we all know, Vision 2020 Right to Sight is one of the most important breakthrough in control of blindness and visual impairment in the world. To strengthen the objective of Vision 2020, WHO made a resolution further in the year 2013 in its 66th World Assembly as Universal Eye Health, a Global Action Plan. Under these resolutions, it set a target for its member country to reduce the prevalence of avoidable blindness and visual impairment by 25% by the year 2019 from the baseline of 2010. Odisha had low eye care indices as compared to other states of India. Comprehensively scientifically designed survey of blindness and visual impairments had never been done in Odisha. Recognizing this fact, the state leadership of Odisha launched the Universal Eye Health Program on World Sight Day of 2017 as Sunetra to strengthen the eye care services of the state. Odisha was the first state in India to implement this universal eye health coverage as Sunetra from the year 2018 to 2022 as its first phase under a slogan of Eye Care for All by the year 2022. Approximately 117 crores have been released for this program over 5 years. Now it is an ongoing project and has been renamed as Surendra Sai Divya Drushti Yojana during the year 2024 and 25. Sunetra aims to reduce the preventable blindness and visual impairment by provision of better eye care service for all by strengthening infrastructures and skill development of human resources. Department of Health and Family Welfare, Government of Odisha, made a Empower Committee to fix some strategies to implement this program in our state. They plan to assess this magnitude of blindness and visual impairment of the state and use of already developed tool for gap analysis of both resources and performance at the district levels to strengthen and empower the existing pyramidal healthcare level of the state, capacity building with appropriate training and placement of trained eye health personnel at the district levels, and to digitalize the eye health data for a future big data analysis, and special focus was given in eye care for the children, and to create a center for skilling and planning, and to bring synergy between public and private eye health care providers. Coming to the achievements from 2018 to 2023, to prevent visual impairment due to refractive errors, 8.9 lakh spectacles have been supplied to the beneficiaries of all age group with refractive errors. To provide comprehensive primary eye care health care, fixed vision centers are being established at each community health centers in a phased manner. Out of requirement of 372 fixed vision centers, constructions of 250 fixed vision centers have already been completed, and approximately 22.03 lakhs people have been benefited by these fixed vision centers. To improve the quality of eye surgeries in our state, modular IoT in 8 government medical colleges are already being established, and in other rest 4 government medical colleges it is under process. To provide eye care services to the unreached populations and tribal areas or something like that, and strengthen the referral service, mobile vision centers are functional in all the districts of the state. The mobile vision centers are functional with hired vehicles and ophthalmic equipments. Ophthalmic officers move with these mobile vision centers and cater the service to the unreached areas. With this, 2.75 lakhs people have been benefited through these mobile vision centers. Ophthalmic instruments and equipments have been supplied to these fixed vision centers and all mobile vision centers to improve the quality of examinations. Regarding school eye health program under Sunetra, screening of all the students from class 1 to 10 of all the government and government allied schools are done by trained teachers. Vision checkup of all these referred students with suspected vision problems by these trained teachers was done at camps, at block levels and at medical college levels by the ophthalmic assistants or ophthalmic officers.
How many slides more?
1 minute. Approximately 2.42 spectacles have been supplied to the school children. So these are these COA and 90 seats of COA, certified ophthalmic assistants and certified surgical assistant course have been introduced, and 15 days of refresher course of existing ophthalmic assistant has already been done in 3 premier medical college. So to conclude, the ultimate goal of Sunetra is integration of eye health care to the general healthcare systems. Achieving these short-term goals as important as laying foundation for long-term plans, and Odisha could be the model state in India in universal eye health coverage. I acknowledge this present member of this unit under Universal Eye Health Society for sharing their data to me. Thank you for your kind attention.
Thank you, Dr. Rabindra.
Any steps have been taken for digitization of the data?
Yes, madam, there was a slide because due to lack of time I just omit that. For the actually the idea of digitalization came to Sunetra from a organization called IRIS in US. It is called Intelligent Research Insight. This is a first electronic data record in America. They have taken that idea to implement this digitalization data in our state, and for that they first appoint a data entry operator to include the different patients' data. Later on, government decided to merge with Odisha Management E-Information Systems. It along with this vision health parameters, it also includes the other health parameters. So that will provide a big data analysis after a few years. that will help in the research purpose.
Thank you, Dr. Rabindra.
Thank you.
Our next session is that of young Odisha. They are the torchbearers of tomorrow with newer ideas, youthful energy, and promise of a bright ophthalmic future for OSOS. Our first speaker is Dr. Praveen Kumar Subudhi, and meanwhile the next speaker should also be ready. Over to you, Dr. Praveen.
So at the outset, I would like to thank OSOS and AIOS for giving me this opportunity, and especially Sarmishta Madam for keeping me young at the age of 40s. So how many of you are in private practice? Can I have a hands up? Private practice. So we all know what are the problems associated with our private practice. We have a lot of financial pressures, we have regulatory pressures, we have competition and patient volume increase year on year, and human resource management. So there are so many things comes to our head, and so much of pressure is there to take care of our practice. And the only thing we can help in growing our private practice is cataract surgery, as we all know. Cataract and refractive is the bread and butter of ophthalmology, and other specialties can only add to your passion, but it cannot be the primary thing which you can perform in your practice. So what is the reality, the sad reality we have in keratoplasty or a transplantation? It's the duration of the surgery. And we need to know there are always associated risks of rejections and failures, which we need to accept like any other transplant. And we need to have a regulatory body to establish so that you can perform transplantation at your center, that is HOTA or an iBank association. The problem in any private practice is we have a very high stake scenario where achieving the desired outcome is expected with certainty, but yet any deviation from this outcome are not tolerated. So that is the thing, sad reality we need to understand. And the full thickness keratoplasty, which classical keratoplasty or transplantation which we used to perform, because this transplantation has become outdated, has come in the backbench because it has so many graft rejections, because of the multiple sutures, there may be suture infections, suture related astigmatism, and these are the problems. Patient doesn't have a very good optical outcome following the procedure. Hence, we have to upgrade ourselves as a cornea surgeons to endothelial keratoplasty, which can be broadly classified into a Decimet stripping endothelial keratoplasty, ultra thin DSEC, and the new generation, and the new generation surgeons perform a DMEC, which is Decimet membrane endothelial keratoplasty. And we need to know where are the cases where we perform these endothelial keratoplasty. That is, the PBK is the pseudophakic bullous keratopathy, FECD is the Fuchs endothelial corneal dystrophy, failed grafts, ICE syndrome, that is iridocorneal endothelial syndrome, and CHED syndrome, and these are basically broad indications where we perform an endothelial keratoplasty. The advantages of endothelial keratoplasty over a classical penetrating keratoplasty, it's a sutureless procedure, the post-op visits are less, and the risk of rejections are drastically reduced compared to a full thickness penetrating keratoplasty. But the problems which I faced when I started this endothelial keratoplasty, I was relatively new because during my fellowship I did not had an opportunity to perform endothelial keratoplasty. So directly I had to jump to perform endothelial keratoplasty in my private practice, and it has a very steep learning curve, and there is an unpredictable journey. I'll show you. In this case, it's a very interesting case. This is a case of a DSEC which I performed in a failed graft. After removing the thick hypertrophic epithelium, I had some view of the antechamber. So now I had to stain the chamber or the Decimet membrane with the trypan blue. And you need to just strip the Decimet membrane. Here, mind you, in these cases, the Decimet membrane is very tight, it's very difficult to remove. So after doing the lenticule, performing the lenticule, you introduce this lenticule into the anterior chamber. After putting the air, the oops movement happened. I could not see the lenticule. Because it was a post cataract surgery and the lens was little bit subluxated and there was no proper posterior capsule, the lenticule was almost in the vitreous chamber. So now I have to open up the antechamber and I have to pull the lenticule out of the vitreous to the antechamber, and finally I could achieve the tamponating the lenticule to the cornea. But after this many manipulations, anybody can think this graft is bound to fail. But somehow it became successful. But this is the unpredictability. So another case, so there are risks of failure associated with these endothelial keratoplasty, and when you have failure, you feel dejected, you feel disheartened, and you feel like quitting the procedure, because there is a risk of graft losses, there is a risk of graft failure, and the unpredictable journey which I was telling. So these are two interesting cases. In this case, I performed a DSEC, and it took 3 to 4 weeks for the graft to clear, and finally it became successful. But another case, the surgery went very well, successfully went. It was a pre-cut graft and everything went well, but within 4 weeks, the graft went to a primary graft failure. So this is the unpredictable journey you have. You can have success, but the success and failure can be known only after 2 to 3 weeks. So if you have a primary graft failure, then you can again go for a removal of the old graft and replace it with a new lenticle. Finally, this patient had to suffer for another 6 months. After 6 months only the patient could see. The best part is the patient was loyal to me, and it continued to me, and did not went to LV Prasad, it came to me only. So finally the journey continues, where the DSEC, where we have to upgrade yourself from DSEC to DMEC, and that is the future for every cornea surgeon, and it is the DMEC which gives the patient the best visual outcome. And here just the video, this is also an oops moment for me here in this case of phaco DMEC. I'll just show you what's the oops moment was that. So I introduced the scroll into the antechamber, and as I was unscrolling the scroll, I could see the scroll was opposite, was inverse. So I had to deepen the chamber, and while deepening the chamber, you can see the oops moment, the lenticle came out, the scroll came out. Again I had to reload it and had to put inside the antechamber. Finally the patient did well. Hopefully, as I said, it is again a very unpredictable journey. So to conclude, in summary, endothelial keratoplasty has a strong and expanding role in private practice due to its advantages over traditional transplantation methods, the potential for improved satisfaction, and ongoing advancements in surgical and donor tissue technologies. As more private practitioners will adopt these techniques, the scope for endothelial keratoplasty is likely to continue to grow, benefiting both surgeons and patients alike. So thank you for the kind attention.
Thank you, Dr. Praveen. So our next speaker in line is Dr. Chittaranjan Mishra.
Slide is ready. Question for him? None?
Next.
No. Praveen, when you found that the patient has not gone to LV Prasad, were you particularly happy or unhappy?
I don't know, sir. I was unhappy because the patient keeps on coming, and that day I was. I finally became happy.
Praveen, actually, any new procedure which we have not learnt is a difficult procedure to begin with. In private practice, there's nothing extra. There are short courses available where you can go and get the training done. My question is, do you need any extra equipments to make sure that your journey becomes smooth?
Yeah, if you have the luxury of IOCT, like intraoperative OCT, that is the biggest boon you can have, because on table you can see the scroll and you can manipulate, and if you see there is an inversion, those things can be done, because particularly DMEC scrolls, there is a particular orientation. It has to be like this, it should not be like this. So those scrolling things, unscrolling, whilst unscrolling, whether the scroll is upwards or downwards can be known while with intraoperative OCT. So that, yes sir?
Okay, thank you, Dr.
No,
Praveen.
but Praveen, you just that why letter away from that luxury, because you already have the Lumira 700. Why don't you get the IOCT?
No sir, it is not compatible to Lumira I. It is compatible to Lumira.
You have the 700, I believe. You don't have the 700?
700 is with Retina, sir, not with me.
Oh, acha, so there is the differentiation. The fractionation, so to speak.
Put your application to your reserve bank.
Start.
So, thanks to the Governing Council of OSOS and Chairman Scientific Committee, Sir Mr. Madam, for the opportunity. I have this topic, decreasing the risk of ARMD, role of diet and vitamins. I believe all of us are prescribing the macular vitamins to the patients in the OPD. All of us are getting questions regarding the decrease in the risk of progression of ARMD, and it's not specific to a retina specialist only. That's why this topic is chosen. So in the pathogenesis, we all know that oxidative stress, inflammation and angiogenesis, and more particularly oxidative stress, that plays a role in the dysfunction of the RP photoreceptors, and this causes the disease. And regarding this table, we all are familiar with this. Many of our teachers are there, and all of us have been asked this question during our residency journey. So ARDS age-related eye disease study 1 formula was having vitamin C 500 and E 400 international unit, beta carotene 15, copper 2 and zinc 80. And in ARDS 2 they have added lutein and zeaxanthin 10 and 2 respectively to this, and beta carotene they have removed. Why I am showing this? Because ARDS 2 formulation, after 6 years of taking this formulation, there was a risk reduction of up to 26% in the people, those who have taken this. So this is very important slide from this talk, if anyone wants to take. Actually ARDS formulation benefits people having intermediate or late ARMD only. That means those patients who are not having ARMD or early AMD are not going to be benefited from this ARDS formulation, so that so far as the risk of progression to blinding ARMD is concerned. Now coming individually, vitamin C and E humans cannot synthesize, that's why we need to give it from outside, and especially the antioxidant property is helpful in this. Remember the previous 2 slides I was telling about the oxidative stress that is playing a role in the photoreceptor damage. Now coming to the lutein and zeaxanthin, the carotenoids, we all know the carotenoids. So green leafy vegetables, what are the green leafy vegetables? Is it the traditional green leafy we are telling? May not be. It is what I searched and I got this broccoli, lettuce, spinach and pumpkin, yellow capsicum and eggs. One non-veg in this. So there are different studies as I have outlined over here. All of them, they have proved that there is a risk reduction in the progression of ARMD with this carotenoids, with taking the carotenoids. Coming to lutein, lutein helps in increasing the macular pigment density, and ARDS with lutein and zeaxanthin had a reduction of 26% risk of progression to advanced ARMD. And coming to the polyunsaturated fatty acid, docosahexaenoic acid and eicosapentaenoic acid are the 2 that were studied, and including Blue Mountain eye study, they have found that there is decreased risk of progression to ARMD related vision loss if we are taking these things. And seafood, fruits and nuts. Again, this is very important. See, fish is good. Like, I'm sorry, I have no differentiation about the veg, non-veg quality, but the fishes which are rich in omega-3 fatty acid are mackerel, salmon, fish, herring, tuna and sardine. So here probably we need to find out whether rohu and katla are coming. These are not there in the list when I saw. So we have to see for these fishes. Coming to copper, copper was added to supplement formula containing zinc to reduce the risk of copper deficiency anemia. That we must know, because people who are taking zinc, they are more prone for copper deficiency anemia. Coming to zinc, it helps in the regeneration of rhodopsin and phototransduction cascade, and 80 milligram of zinc was found effective in comparison to placebo. Again, this slide, I want to just spend maybe 20 seconds in this. Please remember, this is a Mediterranean diet pyramid, and at the bottom, can you see daily activity we should do, and this food, like we should physically be active, enjoy meals with others. That is very, very important. You know, more than the food habit, it is the social gathering that they have given more importance. Then daily what should we should take fruits, vegetables, grain, olive oil, nuts, legumes, seeds, and a few times per week if you see fishes and seafood. Weekly, maybe something like poultry or you know, the cheese, and monthly in small amount the red meat and wine is also there over here. Okay, and the big the box you can see over is drink plenty of water. So if you want to remember anything, you know, this is the Mediterranean diet. And if you see a traditional ODI diet, that is this is the traditional ODI diet. weekly sometimes we take, not now. Nowadays the conferences are more, we get more food. But if you see the Trident, what at least I used to take in village when I was
time is up.
Yeah, so this is the last but one slide. These are the commercially available tablets. If I have no financial interest, the upper two are available in USA, and the lower ones, if you take in BD dosing, that is exactly fitting to the ARDS2 formulation. To summarize, intermediate or advanced ARMD patients should be advised for ARDS based supplements, and they have a favorable safety profile. There is less concession on the prevention of ARMD, and adherence to a Mediterranean diet should be encouraged. Thank you.
Thank you, Dr. Chitta.
I'm not sure we want to remember that diet list at all.
So the basic question is, to what extent do you think that so-called vitamins, macular vitamins in OPD,
exactly,
reduce the risk of AMD?
Yeah, so if we take it for, according to the ARDS2 study, if we take it for 6 years daily, then there is a risk of 26%. More fun, that's the
Thank you, Dr. Chitta. Our next speaker is
Thank
Dr. Smruti Rekha Priyadarshini.
Before starting the video, I have a video to showcase. Before starting a video, I'd like to just brief that this is about neurotrophic keratopathy. We know that till now we have been treating neurotrophic corneas with lubricating eye drops,
Please
amniotic
stay back,
membranes.
Dr. Lokanath. I'm sorry.
And now we want to find a cure for that. We want to treat the underlying condition so that we treat the cause and not the effect. Hello everyone, I will be discussing a case of corneal anesthesia following varicella zoster infection managed successfully by indirect corneal neurotization technique. A 24-year-old female was presented to us in 2007 with chief complaints of white spot on the black portion of the right eye since childhood, associated with on and off redness. There was history of chickenpox infection during childhood. Visual acuity was counting finger close to face, and cornea showed a hypertrophied vascularized scar. The patient again presented in 2019 with pain and redness of 1 week duration. There was minimal conjunctival congestion, and cornea showed a scar with an overlying epithelial defect. A diagnosis of neurotrophic keratopathy stage 3 was made, and corneal scraping and glue BCL was performed. At 1 month post-op, a central vascularized leukomatous corneal scar was noted. The corneal sensations were completely absent. Considering the prolonged history and clinical findings, corneal neurotization by the indirect technique was planned. The corneal sensations were checked, followed by checking the dermatome supplied by the nerves. Dissection and mobilization of the sural nerve was done. Then the contralateral supratrochlear and the supraorbital nerves were isolated and they were identified. Subcutaneous incision was made and a tunnel over the nasal breech was constructed to the ipsilateral eye. The sural nerve was passed through this tunnel. Further, a blepharotomy tunnel was created and the nerve was passed into the superior conjunctival fornix and further to reach the perilimbal area. The nerve was dissected to expose 4 to 6 fascicles. A 360-degree peritomy was done and sclerocorneal pockets were made 1 mm into the cornea. These nerves were then dissected at appropriate length and passed into the sclerocorneal pockets. Fibrin glue was applied and the conjunctiva was closed using 80 vicryl sutures. The other end of the sural nerve was dissected and end-to-side anastomosis with the supratrochlear nerve was performed and the blepharotomy incision was closed. At 1 year post-neurotization, the patient reported that she could appreciate the installation of eye drops in her right eye. From the date of surgery, she had had only 1 episode of epithelial breakdown which was managed conservatively. Sensation has increased in all quadrants ranging from 25 to 60 mm except the center. Vision potential checked with scleral lenses improved from counting finger close to face to 20 by 320, and we have discussed with her the option of lamellar keratoplasty for further visual rehabilitation. Corneal neurotization addresses the underlying pathophysiology of neurotrophic keratitis and can be considered as a preliminary step before further interventions such as keratoplasty.
Thank you so much. Thank you, Dr. Smruti. Any question?
When do you expect the corneal sensation to come back?
As in literature, it has been reported that the neurotization, the rate of neurotization is usually 1 millimeter per day, but it doesn't happen in real time. So normally it takes more than 6 months for the neurotization to start, but in our case we saw that it took more than a year for the and even after 4 years also the center was not as good as the periphery. So I think it will take some time, and maybe this case was one of the first cases that I had done. So maybe more of surgical handling. And
if one neurotization fails, is there any scope for repeating the procedure again?
Yes, we can do. It is not that we cannot do. We can always do another one, but we have to again counseling the patient for such a big surgery would be difficult. Thank you.
Thank you, Dr. Smruti. I request one and all to please stay back for a group photograph. The concluding remarks will be given by our President, Dr. Srimant Kumar Behra, sir.
Thank you, delegates. This is the OIS session in APAO conference, and you have attended in large number. Now we have listened to our national and international acclaimed speakers of our society, and very patiently you are listening, so I am thanking you very much. Now I requested the speakers to come to the dais for a photograph, and we will conclude the session.
We
please
request
stay down,
everyone to join. Let all of us join and take.
First speaker, madam, the protocol.
Okay. Please don't go away. We'll have a group photograph. All of us, all OSOS members.
Request everyone, please do join us.
आसी जा सब बस जा आ गोटे धाड़ी ठिया हे जा पूरा लंबा ही बस बड़ा से लंबा ही बस जा मैडम आसंतु ठिया आपन को सर अनुराग आज मुरलीधर भाई नरेश क्लोज प्रमोद यार क्लोजर तो सेठी बसुनु बेस्ट बसी गले बेस्ट हो नरेश दिसुनी नरेश कम फ्रंट